Good evening, and welcome back to the Humble Healer podcast. And thanks for tuning in. And today we will continue with the Opioid Use Disorder series. And previously, we talked about the history of the uniquely American opioid epidemic that had killed hundreds of thousands of Americans since it began over 20 years ago. And now we'll talk about the clinical aspect of this epidemic and disease, and the important part of how to recognize and help those with opioid use disorder or OUD in your family or friends or patients that you treat in your clinical settings. And for anyone, it could be yourself if you try to get help. This could be also good information for you. And this is Dr. Quang Lei. If you like the information, please like and subscribe to the channel and turn on the bell notification. Thank you so much. So what causes addiction to opioids? It is not yet known why some people become addicted to opioids and then others do not. Typically, opioids produce pain relief and for some people, euphoria, a sense of heightened well-being. Experiencing euphoria after taking opioids may be a warning sign of vulnerability to opioid addiction. This euphoria can even occur in people using opioids as prescribed by their doctor. One of my patients in the past who came in to get Suboxone from me said that her and her boyfriend, before they became addicted, they just took an oxycodone. At the time, it was 30 milligrams since they were already tolerant to the medication. And they said, yeah, him and I, we just took an oxy 30 and we had a party. So for those who had really high euphoric feeling with that, they are at high risk, unfortunately. Early in the process of the opioid use disorder, people may take the drug because of pleasurable effect. Over time, the pleasant sensation diminish. A person may take opioids more frequently or at a higher dose to restore the euphoria, or as the condition progress to avoid withdrawal symptoms. Unfortunately, this is not something that is not gonna last for patients or anyone. The first hit is the best hit that you will ever get. After that, you will get diminished effect, and eventually, not only you won't feel it, but you just take it in order not to have withdrawal symptoms, which I will go over later, which could be very, very unpleasant and cause a lot of fear among the opioid addicts patients. Opioid works by hijacking your brain, and it cause a massive release of the dopamine in your brain all at once, causing this intense pleasurable sensation. And for some people that have used it before, they describe that all their pleasant memories, not the bad one, the pleasant, almost all of them since childhood came back. I mean, it was described by these patients as amazing feeling, especially with heroin or other highly potent medications or drugs like fentanyl. But that's it. And then after that, it's all downhill from there. So patients, unfortunately, they keep trying higher dose and higher dose to the point where they will get overdose and respiratory depression and die without anyone intervening in order to reach that euphoria or even to close to that euphoria they've ever had. But you won't get to that point after the first time. So taking an opioid regularly increases the risk of becoming addicted. The time it takes to become physically dependent varies from person to person, but it is usually a couple of weeks. Taking an opioid for a day or two is not a problem for most people, but some studies show that even the first dose can have physiological effects that can make someone vulnerable to opioid use disorder. If there's a pattern of prescribing by a lot of providers or clinicians out there, giving patients opiates, oxycodone, every 4 to 6 hours, and theoretically speaking, if you take it every 4 hours, after 3 days, you can develop withdrawal symptoms already. So I will talk more about the prescribing pattern in the next episode on this series. Prescribers play a big role in creating this addiction and dependence on their patients also due to lack of training and education. So let's learn how to recognize symptoms and signs of OUD to help ourselves, our family members, our friends. Physical dependence, it is a physiological change that occurs when using a substance. When the person stops taking the drug, they experience withdrawal symptoms such as cravings and sweating. It is important to understand that a person can be physically dependent on opioids without unhealthy use. For example, a patient with cancer who has chronic pain may be physically dependent on opioids, but not addicted to them. Increasingly heavy, frequent, unhealthy, or risky use, the person continues to use an opioid even though it can cause problems with health, safety, financial security, or personal relationship. A person with opioid use disorder is unable to control the use of opioids, and behavior associated with getting and using opioid increasingly interfere with daily life. I've had patients taking initially at 5 milligram oxycodone, going up to 10, 15, 20, and then 30 every half hour just to avoid withdrawal symptoms. And eventually the pill is not enough anymore. And unfortunately, that the next one will be heroin, which is a lot cheaper because 30 milligram oxycodone used to cost $30, probably more now with the deflation of the inflation of the dollar. So eventually you run out of money. For cravings, these are overwhelming physical and emotional urges to take the drug despite an understanding of potential consequences to well-being. I've had patients walking the street. Actually, I've seen them on the street, um, asking for money in order to reduce the withdrawal symptoms. And there's no longer any concern about self-respect or health or hygiene or anything like that. It's all about survival now. And that's the sad part about it, what that drug can do to you, opiates. Other signs of an opioid use disorder, someone struggling with an opioid use disorder may not show signs right away. Over time, there may be some signals that the person needs help, such as now, these patients can hide their symptoms. They can be functional, they can be clever and hide those symptoms and function. But just watch out for drowsiness, changes in sleep habits, weight loss. When you use opioids on a regular basis, you do not have appetite. You do not care to eat, and you don't have libido either. So no interest in sex or any most other pleasurable activities that patient without OUD would normally enjoy. Frequent flu-like symptoms, decreased libido, lack of hygiene, changes in exercise habit, isolation from family members or friends, stealing from family members, had friends or business, new financial difficulties. Even when suffering from a substance use disorder, a person may deny that the problem is serious and resist effort to help for a long time. When ready and willing to start a recovery process, it is important for the person to have access to resources and to start treatment as quickly as possible. For treatment, opioid use disorder is a complex disease and treatment works best when tailored to the individual. There is not a single approach that works well for everyone, and a person may try several therapies before finding the ones that support lasting recovery. Treatment for opioid use disorder is available from healthcare professionals and may be provided on an outpatient basis or through a residential program such as rehabilitation center or rehab. Treatment in any of these settings may include use of medication such as methadone, buprenorphine, or naltrexone paired with support program that can help people recover. We'll go over this later on medication use for OUD. For hospital treatment, it is rare for opioid use disorder alone. People with substance use disorder may go to hospital emergency room because they are in crisis due to physical or emotional distress. Most hospitals provide an evaluation, assess the patient's primary need, and then connect the patient to treatment. The hospital may admit someone who also has significant medical problem in addition to opioid use disorder. However, if patient had signs of intoxication from opioid use, and it may affect their respiratory drive or clinical picture, then they may need to be observed and provide treatment. There is a growing movement among the emergency medicine physicians and providers to learn how to treat these patients instead of referring to a center, since you want to help them with withdrawal symptoms. And we'll talk more about this, since most of these patients presented to an acute care setting, especially emergency department, um, as they get sick. Opioid overdose treatment with naloxone can be used in an emergency situation when a person has taken an overdose of opioid drugs and has stopped breathing or is in danger of stopping breathing. Naloxone flushes the narcotic out of the brain's receptors and can reverse the overdose, but it does not address the underlying opioid use disorder as addiction treatment would. Sometimes it can be tricky when you look at a patient that may have overdose, but they just get sleepy and drowsy. So you have to keep an eye on them to make sure they're safe. Sometimes they may stop breathing, and you may save a life by providing that naloxone treatment or Narcan as a brand name nasal spray, very easy to use. Unfortunately, with fentanyl and much more potent opioids, it takes a lot more medication or Narcan in order to reverse the overdose. For opioid withdrawal treatment, or called detoxification. The first part of treatment is addressing withdrawal, helping the person rid the body of the opioid. When a person with a physical dependence on opioids stop taking them, they experience withdrawal and symptoms within 6 to 24 hours. The amount of time depends on the drug the person has been taking. Withdrawal from opioid can cause sweating, chills, anxiety, agitation, muscle aches, insomnia, abdominal cramping, nausea, vomiting. Withdrawal symptoms may increase in severity over 72 hours before beginning to ease. Unlike withdrawal from other drugs such as alcohol or benzodiazepine, withdrawal from opioid is uncomfortable but rarely life-threatening. Treatment can include supportive measures to ease symptoms and help ensure the person is safe, including administering methadone or buprenorphine. Once the drugs are out of the person's system, continuing treatment is recommended to avoid relapse, resuming of the opioid use. It is common for patients with OUD to develop secondary mental health disorders such as anxiety and depression. That's why in this setting, we talk about dual diagnosis, which is a high coexistence between mental health disorders and substance use disorder. Addressing OUD has to be coupled with treating the coexisting mental health disorders. Outpatient and residential substance use disorder treatment. The person with the opioid use, OUD, may decide on outpatient treatment or enter a rehab facility for more concentrated therapy. Treatment costs and insurance coverage vary. Consult with the insurance provider for specifics on this. Most rehab or residential, they will know what insurance cover and how much and so on. So it's important to call them first. And then you can ask for admission. Counseling for opioid use disorder. For OUD interfere with many aspects of a person's life, counseling and behavioral therapy can help a person address underlying thoughts and behavior associated with unhealthy opioid use and learn ways to counteract them. Depending on the treatment center, group therapy, relapse prevention training, vocational and educational service, community-based or family-based support, mental health assessment, and other resources may be available to help support continued recovery. Drugs for addiction. Several drugs are available that can help people continue opioid use by reducing cravings or blocking the pleasant feelings that the opioids cause. These drugs can be part of person therapy for opioid use disorder. They are therapeutic treatment, not substitute for the drug causing the person's problem. People who are highly motivated and have good social support tend to do better with the support of these medications. The first one is methadone, which is a medicine provided in a clinic or inpatient setting to treat opioid use disorder. Methadone helps with withdrawal symptoms and cravings. It can be taken as a pill, liquid, or water. It can be prescribed by a doctor to treat pain also. Another medicine is buprenorphine, also relieves opioid craving but without producing euphoria. Prescribed by many physicians for office setting. This is typically taken in a daily dose, placed under the tongue. It can be delivered as a once per month injection or through thin tubes inserted under the skin that last 6 months. Those later formulary, the tubes under the skin, like a contraceptive for women, may have difficult insurance coverage due to its being relatively new, as well as a monthly injection. Both methadone and buprenorphine activate tiny parts of nerve cells to control cravings, called the opioid receptors. They are effective and similar in safety and side effects. They may be used as maintenance treatment and in some cases to taper opioid use. Traxine is very different from methadone and buprenorphine. It does not turn the opioid receptor on, but instead blocks the euphoric and sedative effects of opioids. Patient system must be completely free of all opioids before beginning to take naltrexone. It can be taken orally or once per month injection. Brand name is Vivitrol. Training in administration of naloxone for loved one with substance use disorder is offered in most communities. Mental health treatment, we talk about that, coupled with group and individual counseling therapy for both OUD and mood disorder, as well as medication to treat mental health disorders. Preventing opioid use disorders. What should you do if your doctor prescribes an opioid drug for you? To lessen the chance of developing a substance use disorder, follow your doctor's order carefully. Make sure to only take the medication as prescribed. If you are going to have a medical procedure, you should have a conversation with your physician beforehand and about pain control. What I usually do, I help patients with giving them just twice a day of an opiate, alternating with something like anti-inflammatory like celecoxib, which is a later generation NSAID, to help reduce the need to use opioid. And you can also use Tylenol 1,000 milligrams twice a day, which can also be helpful. So the principle of giving medications for us to minimize harm and adverse effects is to use more medication but reduce the frequency. So in this particular case, it will reduce the need for opioid, the risk for opioid dependence and addiction and withdrawal. You can ask the physician or provider question what is the strategy for pain control and is the number of pills, is that the right for you? What other options do you have other than taking an opioid to help control the pain, especially after surgery? So as I mentioned above, that's what I usually do, and I have assisted patient after surgery on Suboxone on pain control. So next time on this series, we'll talk more about a physician perspective or someone I've been practicing addiction medicine, opioid, especially use disorder for 10 years. So I'll give you my perspective on how I approach this problem and how we can help. This is an important issue that affect not only the patient, but their families, the communities around them, and society, because we can help bring them back to society, integrate them back to the community, and help them become a productive member of their family, of their community and society. It's a ripple effect that will affect everyone around them. It's a big deal. Most of these patients are young and productive, the long career or long life of productivity ahead of them. So very important to commit or invest in these patients and treat them with kindness and minimize stigma, treat them like a human being and with compassion and dignity. So thank you for tuning in, and please hit the like button and share and bell notification. And we'll have another episode on this series. Take care and good night. Thank you.